Hello, my dear friends. Continuing with our DNB paper discussion series, now we will be starting with the December 2025, the most recent exam. And you will realize again what I have been telling you over so many paper discussions that the previously asked questions, often many of them are going to be repeated. And a lot of questions they are asking specific things, which is what you need to mention. So don't go about beating around the bush, writing unnecessary things. They will not fetch you any marks. If you want to clear the paper comfortably, write what is asked and get some structure to your answers. Wherever possible, there should be a flow chart or a simplified table or a division of points. It should not be an essay type answer. Understand, people who are checking your papers, they are going to be senior surgeons. They don't have the time, patience, or inclination to go through your essay answers. If it is point wise, if there is a flow chart or if there are tables and figures, that is ideal. Please think that you have to make it easy for the examiner to evaluate your paper, right? And as much as possible, avoid changing the order of the answers and stick to the format of the question. Okay, so if there are 10 questions per paper, go in the order. Many times they will give you separate paper sheets for separate sets, like two sets, part one, part two, and the 5 questions in each paper set. So, like that, stick to the order. Avoid changing these things as much as possible. This paper we'll be discussing in two phases or two sessions. 5 questions will be discussed in this module and the remaining 5 in the next module. And you realize normally paper 1 is general surgery, basic sciences, biostatistics, those kind of topics predominate. Many of the questions in this paper that I will be discussing, if you go through the last 5 year solutions of mine, you will find the same questions or at least similar questions there. So don't think, oh my God, are they asking such tough things? Many of these things have been asked before somewhere or the other. So let's start with the discussion. Let's start with the first question. Now here they have put a 10-mark question up front, and it is actually a very easy question for 10 marks. So they are asking you role of antibiotics in various classes of surgery in reference to types of the wound classification. Means depending on the type of surgical wound, what is the antibiotic role? So first thing you need to know, what are the classes of surgery based on wound. This is the CDC wound classification, very famous. It has been asked many times. So first, write what each class means, what surgeries are there, what is the infection risk if you don't give antibiotics, and whether antibiotics will have any benefit or no, and in what order are you going to use them. You follow these things day in day out because you are doing surgeries left, right, center and giving antibiotics, but are you even following many of these practices? Because many times we are overusing or abusing antibiotics. That's what they want to see. At least do you know the theory behind each? So whether you did a DU perforation surgery or whether you did a lap chole or whether you did an MRM, what should be the post-op or perioperative antibiotic protocol? Right. So first, write the 4 class of surgical wounds, which goes in the order clean, clean contaminated, contaminated, and dirty. Then explain each of these wound categories. In a clean wound, there is no entry into body cavity. So these are superficial surgeries. You can give some examples also, like a hernia repair, inguinal hernia repair, MRM, thyroidectomy, lipoma excision of the subcutaneous area. So these kind of surgeries are going to be clean surgeries. Whether you give antibiotics or not, the risk is low. Okay, risk is less than 1 to 2%. So what is the role of antibiotics here? Normally, no antibiotic is needed. Okay, normally no antibiotic is needed unless you are putting a prosthesis like an implant. So in a hernia mesh surgery, you should give antibiotics. Or if the surgery is going to be prolonged for several hours, patient is high risk, like he has a history of infective endocarditis, or he has metallic valves, or he has a valvular heart disease, those kind of patients. And what antibiotic at best you will use in these patients? Single dose cefazolin or any broad spectrum antibiotic prior to incision, 30 to 60 minutes. This is usually going to be given at the time of induction of anesthesia. So when anesthetist will start the induction, first they'll give the antibiotics, do the induction, then you will paint and drape, and by the time the incision is going to be taken, 30 to 60 minutes would have elapsed. That is ideal. Right. So antibiotics here not indicated unless there is a implant. Second are going to be clean contaminated surgery, that is class 2. What is this surgery? You are entering a body cavity, but there is no spillage, like a lap chole, lap appendix, urinary bladder surgery without spillage, resection anastomosis where nothing spilled out. So there should be no leakage. It should be a controlled environment. Best example, lap cholecystectomy. So here the risk of infection without antibiotic is okay. 5 to 10% is not a lot. So here giving one routine preoperative or perioperative dose is indicated. All right. So just single dose. That will be given 30 to 60 minutes prior to the incision of a broad spectrum antibiotic like a cefazolin or whatever is the practice in your local hospital. Can add metronidazole also if you are suspecting a if you want to give anaerobic cover in the setting of a colorectal surgery. Right, but again, this is single dose. Do you know most of the times for class 1, class 2, we give antibiotics for 5-6 days post-op also. Recommendation is not there. Okay, unless there is an implant. Then you come to the remaining two classes. These are quite obvious. So the third category is contaminated surgery. Easy to understand. Contaminated means there should be spillage. Okay, like a peritonitis or perforated gallbladder or a surgery or a procedure in which there was a break in sterility. Like something was touched in a non-sterile area or something like an open cardiac massage. These kind of wounds are going to be contaminated. Risk of infection is 10 to 30% approximately. Here you will give antibiotics not just perioperative but also postoperative, right? At least for 24 to 48 or 72 hours. And here you will cover for broad spectrum aerobe and anaerobe. So normally we'll give a ceftriaxone with metronidazole or a piperacillin tazobactam. These are the commonly used antibiotics. These patients are likely to be in hospital, so they will be given IV antibiotics cover. The fourth category are dirty wounds. Here, the risk of surgical site infection is very high. It is more than 30% without antibiotic cover. Mind you, even with antibiotic cover, the risk is high. Best example, wounds where there is any pus, any IND you have done for any abscess, any place where there is an existing infection like a wet gangrene, or a late perforative peritonitis, purulent peritonitis. So where there is evidence of existing infection, crush injuries, foreign bodies. In these places, you will give antibiotics. And here, apart from that, you will also do local tissue control. The antibiotics depend on the type of wound. Here also you will give broad spectrum. Here also you will give it for at least 5 to 7 days. And it can be IV initially, later oral. And here, very important, local tissue control or wound control has to be done. So don't rely on antibiotics alone to take care of the problem. Obviously, if there is an IND of an abscess, you will have to do periodic wound check, right? To see if there is any residue, persisting information, persisting infection, because that will have to be taken care of. Otherwise, the surgical site infection will not go away. So these are the four categories and the role of antibiotics. See, for 10 marks, it's a very easy question that you should be able to write.